All right. Well, I will do you the honors of mildly embarrassing you then. So, Dr. Colin Chan, thank you for joining us and for our session today. So, Dr. Chan is a specialist ophthalmologist. And not only does he practice clinically, he is also one of the amazing teachers, I think, at University of Sydney. And he also on the side is a photographer and a Kung Fu student. And he will be talking to us today about life and ophthalmology. And so thank you, Dr. Chan.
Thanks, Lucy. And thanks for joining us tonight. I said one of the things which does inspire me is always the thirst and hunger for knowledge, and that's shown by the younger generation. So that's why I do teach a lot, and it's always quite inspirational. So hopefully you can get something out tonight. So I kind of divided this session into a third. The third, I'm going to talk about ophthalmology, and the second third I'm going to talk a little bit about just hopefully what you might find some sage advice on how to tackle life and medicine. And the third is just up to you what questions you might want to ask. So why ophthalmology? Well, you have to kind of remember the generation I came from, which was actually relatively technology deprived. That's what my phone used to look like. And we used to think that having a CD Discman was particularly cool. Makes us seem really nerdy now, but that's what ophthalmologists are. Ophthalmologists are, generally speaking, if you think about career, generally geeky tech head kind of people, because we love equipment. I saw people that follow Star Trek and that sort of thing. You also have to have good hand-eye coordination, but the thing which really drove me into it, and actually my wife gave me this bit of advice, is that it was a nice balance between medicine and surgery. You weren't completely surgical and just operating on everything that moved. You weren't completely medical either and sort of doing long consultations and intellectual discussions, but you're a good balance between the two of them. And the other thing which attracted me is that when I first encountered ophthalmologists, they obviously had the whole work-life balancing going. They essentially had other interests and other things that they wanted to do, and work wasn't all consuming. Having said that, that's not necessarily the thing that you get looking from outside in, because ophthalmology is this rather odd sort of unloved area of medicine, probably because we use really technical, weird terms, which we don't bother to explain to you. And there's a small number of trainees. You hardly ever find us in any hospital because we're usually trying to avoid doing consults. Therefore, we're thought of being arrogant and OCD and, again, not really friendly in any way. And again, it's one of those areas where you were always taught during medicine that you should know the diagnosis within by the time you take in history, like 80 to 90% diagnosis is history alone. Ophthalmology is not like that at all. It's mostly looking and seeing. And so unless you can actually use the instruments and look and see, then it's not a very interesting sort of specialty for the majority. And that's why GPs really hate seeing red eyes, because they don't have the tools to deal with it. But the coolest thing about ophthalmology, and again, I'm going to sound really geeking doing it, is cataract surgery. And I would defy you to find a surgery where it looks as pretty as to what you've done. You've taken this white, dense cataract to something like this. Or I defy you to find a surgery where you can make a difference in someone's life as quickly and as swiftly. It is hard surgery though. You are literally caught between a rock and a hard place. You're in a tight space. Like I remember once talking to an orthopedic registrar, and they were worried about a person having cataract surgery. And they said to me, oh, look, we're worried, will the wound split open when we do their hip surgery? I said, it's okay, we're only using a 2.2 millimeter incision. He said, oh, so 2.2 centimeter incision. I said, no, not centimeter, millimeter. He said, centimeter. I said, millimeter. That's how small we work. And we're working in a 3 millimeter space. And yawning beneath us is this kind of hellish-like creature called the vitreous. Now, the vitreous is somewhere where you don't want to go, because it's like dropping an eggshell into the egg white. And you know how hard it is to fish things out of that. So it's not a place you want to go. And then you've got the iris which follows you around. But probably best if I just show you a video of the kind of coolness of it. So one thing we use nowadays is we use laser to actually do the initial incision points and actually break up the cataract. So this is in triple speed, but you can see we're lining here the incisions, the round opening we're going to make in the lens capsule. We're looking at it in cross-sectional imaging, lining all the incisions, and then I press the foot pedal and off we go. So circle incision into the capsule, breaking up the cataract in the quadrants, and then making incisions. Boom. Now you can tell me that's not cool. So, and then once we're actually done all that, we get to the actual cataract surgery. So this is a densified cataract, again, triple time, because you don't want to sit around just watching me do a cataract in real time. So splitting it, mulching it up, which is called phacoemulsification, which is also used in liver surgery. Same high speed, 25,000 Hertz ultrasound, removing the skin of the cataract, or what we call a cortical matter. And then after that's all done, putting in the artificial lens. And it looks beautiful. I think it looks beautiful, it looks pretty. And it's one of those few surgeries where you actually have to use both hands and both feet. So you have to be, to somewhat degree, slightly ambidextrous, but also ambi-footed. Is that even a real term? I don't even know. Ambi-footed. So essentially, that means you operate the power of your ultrasonic device, or the phaco, with one foot, a bit like a foot pedal, and then you actually have to move the microscope around and focus it with your other foot. So it's actually a bit, when you first start doing it, it's a bit like patting your tummy and rubbing your head at the same time. The other thing which is you may not know is it relies on a degree of audio feedback. So we know how powerful the machine's operating because we can't look at it. We can't turn around and go, oh, in the middle of surgery, let's have a look at what power it's on. You have to actually get audio feedback. So we turn on this video, you'll just hear this kind of noise going up and down the background. So that noise, the louder it is and the higher pitch it is, the more energy I've got. So the only analogy I can have, it's like driving a car. So if you drive a car, then you know, particularly Formula One car, you know from the sound of it what the actual speed of the car is doing. The other thing that we have is that we have, again, sort of injectables. So you may wonder, how on earth do you put a lens into an eye through a 2.2mm incision? That's because it comes rolled up like kind of a spring roll. And so as it actually gets injected, then you'll actually see the spring roll more or less unfold. So that's how you get a 6.5mm lens through a 2.2mm incision. And the thing is that it goes in cold, but once the eye's temperature warms it up, it naturally unfolds. And the other thing that we have is we have augmented reality. So essentially, to orientate the lens in the right direction for astigmatism and prescriptive correction, we actually have to base it based on iris landmarks. So you'll see this kind of axis come up. So that's being projected down one of my eyepieces in a cyclopean sort of way. And then I actually have rotate the lens according to the orientation. So again, I know it may sound geeky, but I mean, when you get to play with these tools most weeks, it's a lot of fun. And again, just to show you something immensely geeky, why don't you watch it in time lapse? So this is the operating room, and you get to sit down. That's another thing with surgery, you get to sit down.
And you get to look straight ahead as well, as opposed to cranking your neck at weird angles.
Yes. Now, the other good job, which you may want to consider, is the anaesthetist. Do you see the anaesthetist in the room? No. Now you see him in the room and he's playing with his phone. So being an anaesthetist on an ophthalmology list is immensely relaxing. See, watch the anaesthetist. He's doing nothing, is he? So, and again, having now over sort of whelmed you with the geekiness of what I do, day one is actually the best day. Like there's, again, nothing in ophthalmology which is better than seeing your patients first day after cataract surgery, because the huge majority will be either 20/20 or 20/40 without glasses. And they will tell you things. They'll tell you things which, again, just make you think what you do is fantastic. They'll say things like, oh, the leaves aren't this amorphous mass anymore. They're actually, I can see individual leaves. I had one guy who barely speak English. He was this Chinese chap who kept saying over and over again, the sky is blue. It is blue. It is blue. It's actually blue. I see the sky. It is blue. And you get other kind of odd comments like patients say, oh, look, didn't know I had so many wrinkles. Actually, I didn't notice my partner had any wrinkles. I might have divorced them now. So these sort of things are what makes ophthalmology really great and fantastic. But having said that, like every specialty you do, you have to deal with the fact that sometimes things will not go right. And patients nowadays, partly because of our fault, expect really a lot from ophthalmologists. They expect you to get it right every time. And because, number one thing, in the back of their minds, they are scared of going blind. As you know, it's been seen in many surveys, what do people fear most? One, dying in pain. Two, going blind. Third is cancer. So actually, blind is above cancer. And because it is such precise surgery, there's nowhere to hide. If you stuff it up, everyone can see you stuffed it up, and including the patient. The other thing which you have to get very used to is one of the few professions where we hardly ever use a general anesthetic. They're always got propofol twilight sedation. So can you imagine you're doing this microsurgery on someone under twilight and they're not necessarily staying still? It's a pretty hairy thing, yeah, to get used to. So there is some caveats to that. Having said so, it's a relatively broad church. You can actually do many different subspecialties within ophthalmology, and some of them are more surgical and some of them are completely non-surgical, such as being a neuro-ophthalmologist, which is more kind of a neurology ophthalmologist all combined. So if you discover you don't like cataract surgery or you don't like surgery in general and you're halfway through the ophthalmology program, you can then divert yourself when you do your fellowship into something more medical. But if you're really surgical and you want to operate all the time, then do something like ocular plastics or surgical retina. You'll be operating a lot. So one thing I am is I'm a corneal subspecialist. And so I do corneal transplants. And this is a video of doing what we call partial endothelial transplant. So I'm taking the back of a donor cornea off, which is the endothelium or the layer which pumps out water. And then sliding it into an injector. And if it seems a bit fiddly, it is. But remember, this is only 100 microns thick. So I'm trying to grab something 100 microns thick without destroying in the process, because you can hear those endothelial cells literally screaming, going, ah, I'm being pulled into this injector. So, and then you've got to actually inject it into the eye and then pull it out through that injector, again, without not killing too many endothelial cells. So, but this is the way we're going. Eventually we'll go towards stem cell transplantation. And then in the end, we actually float it up with an air bubble. And once we float up the air bubble, we stitch it closed and hopefully it sticks. So that's some of the work I do with corneal transplants. But then you can do other kind of crazy things. If you want to be a retinal specialist like one of my colleagues is, and they tend to be on call a lot more. So if you're really into doing a lot of surgical work, and they deal with retinal detachments, which you can see here in this picture. So that's when your retina falls off because you develop a retinal hole because you're short-sighted and you decide to go bungee jumping on one of those Luna Park rides where you get dropped. And so any of you who are short-sighted have done that, it's not a smart thing to do. So this is him again doing in triple speed, a retinal detachment repair. Now, I hope this doesn't look too gross for you guys, but he's putting in ports. One needs to be a light port. One needs to be other ports for instruments. You can see the retinal tear there. He's sucking out that jelly thing. He's now injecting heavy liquid to actually roll, like a steamroller, the retina back. He's going to roll it back. He's going to unfold it. And yes, he's touching the retina, which is like touching the brain. So it's almost a form of neurosurgery. And then he's welding the peripheral retina down with laser. Yep, we get to play with lasers too. We can use giant laser beams. And then he's getting rid of the heavy liquid, putting in air, then putting in a silicone oil, and then he's done. So that's sort of the kind of work you can do. So that's the end of the first third of my talk is that I think in choosing a specialty, not all you will become ophthalmologists, obviously, but ophthalmology is very rewarding, and it does have very high success rates, but also very high expectations. So it's not for everyone. And you have to realize that when you're choosing a specialty, you almost have to choose what you love, but choose also what you can live with. I could never be a pediatric oncologist, which is what a one person, I mean, I would just die every day if I had to deal with kids with cancer. I just can't do it. I can do this. But again, my colleague who does that, I can also deal with that, but maybe you can't deal with poking eyes all the time. So think about what you can actually love, but also what you can deal with on a daily basis. So I'll move on to the next part, unless anyone has any burning questions. So it feels a bit like imposterish to actually sit here before you as a 47-year-old, 20 years into my medical career, 20 years plus, and give you life advice. But yet, I think Lucy kind of wanted me to, so I'm going to do my best. So I guess what would I tell myself if I was 24 years old again, which I'm assuming sort of some of you are, and some of you a bit older than that? Well, I'll tell myself firstly, buy CSL shares. Just kidding. But if you look at that, 22% per year, that's pretty damn good. So maybe you should invest a little bit now.
Should we buy Bitcoins?
No. If Elon Musk isn't buying it, then no. So more seriously, I was thinking what to say. I would say to you two things. One, one of the greatest joys in life is to be a master of your craft, and medicine is still a craft. It's still an art form. It's not just pure science. And you'll understand that more and more as you go more into medicine and discover more things that you just don't know and don't understand, even no matter how much knowledge you have. The second thing I would say to you is to look after your mental and physical health. And that sounds a little bit trite, and I know everyone says it's a cliche, but it is of utmost importance. So how do you do all that? Well, this is a graph I'm very fond of. I don't know where you're aware of it, but this is called the Dunning-Kruger Effect, okay? It's a very famous graph, won I think a Nobel Prize in terms of what it explained, but essentially it measures competence versus how competent you think you are. And we've seen this all happen before. Essentially, the beginning point is that you are the least competent, you are completely incompetent and no good at what you do, but you think you're crash hot. And we've seen this happen everywhere. You see it in every karaoke bar you go to. Person's belting out some tune and they're horrible. You see it on every dance floor party you've been to. Someone just, oh, you don't want to look at that. You see it when you ask your more elderly relatives to take photos. And you know how some of them always like to take the whole body and the feet in it? You've seen it everywhere. So you see this Dunning-Kruger effect, but they think they're great, right? And when you begin your medical career, especially once you begin as a specialist, you'll come out like me and think, yeah, I'm pretty good at this. Because to explain a bit more, I did my fellowship overseas. I went to the US. I actually was part-time at the University of California, Irvine, part-time in a private clinic in Beverly Hills, a pretty swish place. And I spent a year and a half there. And even when I was there, my son was getting the whole Hollywood scene as well. That's just him when he's like, a few months old. But I came back, and you could probably have collected the arrogance oozing off me. I thought, yeah, got my pass. I've studied in the US, crash hot corneal specialist now, ready to take on anything. The first month was extremely humbling. I saw stuff that I'd never seen before. And I was just like thinking, oh gosh, what? Haven't seen this, never seen this before. Why does this complication happen? I was just fumbling. So, and then at the end of that month, I was kind of almost ready to kind of just lie down and die. And I saw this patient who actually appeared to have 3 genetic conditions within the same cornea, within the same eye. And I just went to my colleague who was like 12 years older, an associate professor. And I just said, Jerry, can you come and look at this, please? And because I just walked out saying, patient, I don't know what you have. Yeah, I give up. And he walked in and he looked at it, sat back, and a very authoritative tone said, "This is mixed corneal disease." And patients go, "Oh, yeah, sounds great." And I was going, "Great." Walked out and said, "Jared, what is mixed corneal disease?" He goes, "I don't know, I just made it up." So it just illustrates to you that sort of even people much more senior than you, it just brought home to me that there is so much more you need to know, and even the people who you think should know still don't know. So let's go back to that Dunning-Kruger effect. So initially, when you begin your career, you will think you know everything. And some people will spend their whole career at this point. And you don't want to be one of those, because everyone will know you're arrogant. Everyone will know that you actually are not very good as a doctor, and you'll get bad outcomes, but you'll be so blissfully ignorant that you just like are harming people. So you don't want to stay at this part of the curve. And then once you get past that to some degree of enlightenment, you'll actually start to get quite depressed, because you'll just realize that there's so much I need to know. And then hopefully as you learn more and more, you'd kind of come up, but you realize at the end of the curve, even when you're so-called expert or master of your craft, you will never be quite as confident or as arrogant as when you began, because you will still have a case of what we call imposter syndrome. And that's actually not a bad thing, as long as you stay on this side of the curve and not on that side of the curve. Because if you have some degree of imposter syndrome, you will continue to learn, you will continue to develop, you'll continue to master your craft, and you ever won't be arrogant enough to start to treat people like fodder and not treat them like people. You always be careful and double think, am I doing the right thing for this patient? The problem is if you fall off on the other side, if you start to think so much about your imposter syndrome, and this will happen to you, you'll get complications, you will get lawsuits. I've been through one, I know it. And you will get times where people put you down, or patients complain, or you'll be referred to medical board, and you won't know why. And then you may fall onto this other side of the curve where you're depressed and you think you know nothing. And that's where this next piece of advice comes. Work hard, try hard, be the best you can for your patients, but don't make work everything that you are. Don't let it define yourself. And if I listened to what I know now, I would have never worked more than 4 days a week. You need that day off. You need a 3-day weekend. I know it sounds stupid, but if you begin now and begin that way, believe me, even as much as you think, oh, I'm a specialist now, I've got to work hard, I've got to become busy, I've got to earn money for those private schools that my kids are going to go to. Seriously, you'll get busy if you're any good before you know it. And then you'll look up and you're working 5-6 days a week and you have no life and you're exhausted 20 years down the track. And if you work in more than 1 and 2 locations, you'll just be everywhere over Sydney, constantly a car driving one place, and I've never been quite the one place, and I go to one place, patients complain you aren't there enough, go to another place, patients don't complain you aren't there enough either. So try to leave a bit of space when you first begin work for other things. And that's the other thing I would say, you do more than just clinical work. One of the great things I find actually enhances my work is actually doing things in ophthalmology which are not just seeing patients, whether it be teaching or other things. So I'll just spend a few brief minutes talking about one. I'm quite involved with a group called the Asia Pacific Academy of Ophthalmology, which sounds rather grandiose, but it accounts for 40,000 ophthalmologists worldwide. So it's one of the biggest groups of ophthalmologists. And it spans all the way across from essentially the Philippines, all across Asia to Iran in terms of its coverage. Now, they hold large congresses, and if you ever want to get completely overwhelmed by a bunch of nerds, go to one of these conferences. You'll make 8,000 of them. That's how many ophthalmologists are there. But the problem is you can only hold an 8,000 congress in a big city. And so a lot of the smaller Asian nations don't get a chance to. So I was given this job by my boss, who's the head of this organization, to actually try to make these smaller conferences to be more inclusive and to go to these smaller nations and try to make them have conferences as well, and to sponsor them and to get the speakers to come along. And so I did one in Vietnam, and then I did one in Mongolia. Now, I don't know whether any of you have been to Mongolia, but it's a great place, you should go. There's only about 3.5 million people. most of the money comes from mining. It's a tough place. Plus, they're tough people. It was 10 degrees when I went there. They're walking around in t-shirts, and I was like, what the hell? They eat mainly lamb and doughy stuff because you don't eat to treat yourself, you eat to survive there. And the average residents there get paid zero money. Oh. So if you're a resident, you get paid zero. And then as an ophthalmologist, it takes you 8 months to earn the equivalent of an iPhone. So first world problems, people, first world problems. But you don't get to see, the great thing was I got the opportunity to see this place and to actually make a bunch of ophthalmologists feel very included and very happy they were part of this greater sort of group. And yeah, we had dinner in this enormous yurt. I had fermented yak's milk, which actually is not as gross as it sounds, actually quite nice. And even got to see a bit of the countryside. That's an enormous statue of Genghis Khan. And I'm holding, yes, that is a real live eagle. And I did make the mistake of looking at it and nearly picked my eyes out. And that's the countryside, it's beautiful. But doing this sort of work, again, just makes my life more varied. It's still medicine, but it's just a different kind of medicine and a different way of looking at my profession. And I think that variation makes a big deal. And in the same vein, you should make your life varied as well. You should do more than just work. And that's, as Lucy intimated to you, I think it's good if you have some other passion outside work. And my two passions outside work are Kung Fu, which I've been doing now for about 10, 11 years plus. When I started, I had the flexibility of a turtle on its back. And now I have the flexibility of a turtle on its front. But still, I get to do things like, you know, that's what we call staff, but I get to play with swords. I get to try to actually, you know, break, you know, not talking about taekwondo boards, but I'm talking about real thick wooden boards with my elbows and with my hands. But overall, what it does, it just takes me away, because at the heart, the Kung Fu I do, which is called Shaolin Kung Fu, is actually meant to be a form of Zen Buddhism or mindfulness. Because when you do it, you actually should be focused on nothing else to do it properly. And my other passion is photography. And this is, I do bird photography because whatever you do, you've got to find some way to fit it into your life without, you know, wrecking your work or wrecking your family. And there's a lot of birds around there, and it only takes me like maybe half an hour each week to go and find them. So it's doable. And so this is a photograph. I'm, you know, proud of this one because I actually got shortlisted for a photography competition of a grey fantail down in Canberra. I was happened to be down the University of Canberra teaching, so I took half a day to go do photography. This is Centennial Park. That's a black swan. And I've waited a long time to take a photo like that just to get the actual water droplets right and the feathers right. So, but what doing these other passions also allows you to do, it allows another avenue, another pathway for you to go outside work, because there will be times, if you make work your everything, what happens when work collapses on you? And a bit like these birds demonstrate, there'll be times where there'll be fighting. As I said, you might be sued, you might have a patient complain, you might just be burnt out, and you might literally want to be like this. You kind of want to give up. And so if you don't have another pathway out, something to either distract you, or even something to give you another career or retirement plan, something you can look forward to, then your mental health will suffer. So that's why I'm saying to you in a roundabout way, find a way to actually work hard, be a master of your craft, be good to your patients, try hard, but also to be your best and to be selfless to a degree, you also have to be a little bit selfish. So not going to say any more. That's enough for me pontificating. But remember the Dunning-Kruger effect. I think it explains a lot. And it is one of my favorite sort of graphs. All right, I'm done, Lucy. Any questions?
Sounds good. Thank you for the talk. It was certainly very insightful. We have, well, just I've noticed one in the group chat to start off with. Bit of a question when you mentioned the hand-eye coordination of the 2 hands and the 2 feet. Elsie was wondering, is there anything you do in your leisure to actually practice the hand-eye coordination, being ambidextrous?
So I actually told this story to Lucy when we caught up the other night. No, but once I realized that I was deficient in it during my ophthalmology training, I did a couple of things. One, I told Lucy one thing, I actually would I would go early before I began work as a registrar to the meat abattoirs in Strathfield and actually get pig eyes to then practice my surgery on. Because I realized no one was going to help me to learn how to do this. You can't go up to your seniors going, oh, help me out, I'm not so good at this. You actually have to do it yourself. And then I would practice surgery as a left-handed, but then I would do other things like try to eat left-handed. Your left hand doesn't have to be as good as your right, but it has to be at least sufficient. But again, hand-eye coordination is something which you can practice doing other fun things, like even stuff like sort of, sports, ultimate frisbee, things like that. So anything which actually, because that's the other thing, like when I do bird photography or work as a surgeon, I'm a great believer in being physically fit, because being physically fit then helps your performance. Like there's times I'm actually running after birds, like literally I'm running from one side to the other, get the shot. Now, if I'm a fat old dude, that's not going to happen, is it? Carrying like a heavy camera. So that's the other thing. I think anything you do to keep yourself physically fit will help as well.
That's some good advice. Maybe you will inspire a few of us to pick up some Kung Fu or some sort of martial arts. Like you said, it's good for physical and mental health to have that kind of time to focus. Anyone else have any questions from the group? You can unmute your mic or you can type it in the message box and I will ask it.
I'd be very surprised. It's like 9 o'clock, everyone must be exhausted.
Well, in the meantime, while we wait for people to formulate their thoughts, I had a question of, I guess, just what's your least favorite part of your career? You make this sound, like everything seems very exciting, but is there anything you do day to day and the bread and butter that is not so exciting?
Oh, there's plenty. That's why you have to, every specialty will have a certain subset of the patients who have chronic disease. And that's the most, like, even though they're the ones that need you the most, it's the most depressing. So one of the chronic diseases I just deal with is dry eye disease. And dry eye disease never gets better. You can only control it. And patients who have dry eye disease tend to be they typically have autoimmune diseases. They tend to be very hypersensitive to any medications, so they always react to anything you give them. And so it's this constant kind of, and back and forth, oh, I didn't like that, it made my eyes sting, it made me feel worse. And there's this constant kind of, losing state. So, but I think, again, when you're doing that, you almost have to hang your hat on the people that you have to almost set your bar low and think, okay, if they weren't seeing me and I wasn't doing something, they'll probably be worse. The other thing which I don't like is the administration. Like if I could take documentation, administration, all that out of medicine, then I would. But unfortunately, it's a very sad fact of what you have to do is that that's the other thing I'd say. If you encounter, you never know, again, when your documentation is going to be called up. Patients ask for their records all the time. Patients, as said, may complain to the medical board or may want to sue you. And if you haven't documented something, it hasn't been said. Basically, that's it. And the lawyers will always find a way. And that's the other thing I don't like about the profession. I don't like the lawyers. The lawyers will always find a way to get you. It doesn't matter. And as I said, when I went through an actual lawsuit, I actually had done nothing wrong. But it didn't matter how wrong I had not done something. They always found an angle. They said, oh, you could have done that, or maybe you could have done that, or maybe you should have done that. And in the end, it just became obvious that they wanted their pound of flesh. And the problem is that when that happens to you, you'll take it very, very personally. And my advice to you is don't. But the one way you can protect yourself is to be very good at documentation. But I don't like it. It's very defensive medicine, and I hate defensive medicine.
Yeah.
It's a necessary part of what we do.
Yeah, but I feel like with kind of technology, it's kind of becoming worse rather than better, because everything is expected to be recorded, and everything from a long time ago can all be dug up. Yeah.
And yeah, I said transcription never contains context. And again, it's just the problem is that, you know, I expected as doctors sometimes to do something that we can't. Doctors are very human. Yeah. And there's no other profession which holds itself up to a high degree. As a lawyer, if someone tells you that, oh, you can't, if someone says, I want to do something, you go, well, that's illegal. And then they go, oh, no, I want to do it anyway. The lawyer can still facilitate it. Same with your accountant. The accountant can do something that which is dodgy taxation-wise. And as long as they professionally warn you, they're allowed to do it. Because then you take the can. But as a doctor, if you tell a patient that they shouldn't do something or they shouldn't do an operation, and then they say, look, I'll take the risk, and you do it and something goes wrong, you take the can, not them. So
Yeah.
it's, again, not easy sometimes.
Yeah, definitely not easy. I guess on a less depressing note, what's your favorite day of the week? Like, is it your operating day? Is it your day? Oh, actually, you said day one, isn't it?
Well, my favorite day of the week is Saturday.
Saturday.
I'm not working. I mean, I'm not kidding. It is actually important. I'll say this not to, you know, de-inspire you, but you should really make your favorite day of the week your time with your friends and your family and doing what you enjoy. Work is always going to be there, no matter, yeah, your friends, family, things you enjoy may not be, and they're the ones going to hold you up when work gets too much.
That is wise answer.
Not the answer you expected, but I'll give you the answer.
That's what I expected.
I'll give you the answer. So the best day of the week is actually, as I said, day one, because if you can, yeah, again, you just see the happiness on people's faces. And if you've made a difference by restoring someone's vision, it's a pretty big thing.
Yeah, absolutely.
A fantastic thing.
Yeah. And what was your journey, I guess, from, like, you know, for some of us who are medical students, so from medical student to where you got to now, what were the steps? I mean, you mentioned, I guess, some parts of it during training and fellowship. How did you eventually get to where you are today?
Sometimes I think about it, and I think like I just got lucky a lot of the times. But you need a couple of things. One, you need to talk to a lot of people. You need to actually work out by talking to a lot of people, okay, this is what I want to do. This is the subspecialty, this is specialty I want to do, whatever it may be. And usually the people that you choose them is based on the people you get along with and the people you admire. It's not essentially like almost like because you realize you want to do what they're doing, you want to be like them, and that's the kind of person you are as well. So once you've identified that, you need to find someone. Again, to my things, I say this to my sons, talent will only get you so far. After that, there's having the right tools and having the right coach. And so what you need ideally is someone who will mentor you. And I've been very lucky that every stage of my career, I've had someone above me who's actually been kind enough to actually mentor me and give me good advice about what to do next as one of my steps. So one of my mentors told me, okay, if you want to do ophthalmology, then you've got to start doing some research. You've got to tick these boxes, and then you've got to do that. And other people tell me, well, okay, then you've got to approach the entrance this way. And another person told me, well, you've got to do good clinical work. You've got to go to referees. So I had someone who always mentored me at every stage. And then even when I got into ophthalmology, I was fortunate enough to have people above me who would do the same. So, and even when I became a specialist, yeah, same thing. I have people more senior in my practice. And that's a great thing about group practice, where again, do the same thing and actually mentor me and say, okay, this is what you should be doing at your career. And it's actually, having that is like solid gold. Having someone who actually And the reason why it has to be someone older than you, because they're not in competition with you. I know that sounds immensely cynical, but yeah, as said, Jack Ma, who you would have heard of, actually does a really good talk on this. He's that Alibaba entrepreneur you probably heard of in China, and he actually says what people do at each of careers. People, once they become my age, they actually are more interested in propagating the career of people underneath them than actually propagating their own career. They get to that stage. And why they do, I don't know, but it's maybe because that's what they think they should do. It's the right thing to do, and because someone did it for them. So that's what my advice would be: is actually get yourself a really good mentor.
Thank you, that's really good advice. All right. Anyone else have any other questions? Final call.
Yes, they're all too sort of riveted to say anything, or too bored or just too polite to leave. I'm a realist.
We'll do a poll afterwards, and after you leave, to ask them their real opinions.
Yep, sounds good. But again, if any of you are interested in doing ophthalmology, or just again, I'm open. Lucy has my contact details.
Sounds
any questions, you can always hit me up.
Yeah, anyone? Oh, someone's got a new message. Oh, it's a thank you message.
Nice, thank you.
Yes.
Thank you.
But yes, if anyone is interested, certainly you can email the AMSC email, and we can link you in with Dr. Chan. And so I guess we'll call it a night. Thank you so much again for your time, Dr. Chan, for sharing your life as an ophthalmologist, as well as some life wisdom in general. And thank you to everyone who attended today as well. All right, so I guess we'll call it a night, and we'll log off now. Thank you.
Bye.